Hello, I'm Dilraj Grewal. I'm a vitreoretinal and uveitis specialist at Duke University. And I'll be sharing some thoughts with you about using imaging biomarkers in clinical practice. I have no relevant financial disclosures that pertain to this talk. So really, Martin imaging with OCT comprises of structural OCT, OCT-A, and en-face OCT. And some of the key advantages of faster imaging, especially with the 100 kilohertz engine, are speed and eye tracking that allow us to obtain wide field OCT-A and structural OCTs. And this is important in everyday clinical practice. So just starting off with a case here, this is a 61-year-old male, otherwise healthy, no prior ocular history, who comes in complaining of subjective distortion in his left eye. His visual acuity is 20/20, but if you pay attention, even though the fundus examination is unremarkable, on his OCT, you'll note that there is vitreomacular adhesion with the hyaloid attached to the optic nerve and the fovea. And then right underneath, there is this hyperreflective stress line that's oriented vertically. And this is a feature, an anatomic feature that has been recognized as a prognostic sign for risk of development of macular holes in eyes with vitreomacular adhesion and early vitreomacular traction. So this really helps to explain the symptoms in an individual with an otherwise unremarkable ocular exam. So this patient was observed, and 6 weeks later, you can see that there is release of the vitreomacular adhesion, even though the hyaloid is still attached to the optic nerve, and there is resolution of this hyperreflective stress line and restoration of normal foveal anatomy with restoration of the normal foveal contour, and his symptoms are resolved. So this really tells us that OCT is indispensable. In fact, I consider it to be an ocular vital sign that I obtain on almost every single patient that I see in clinic. And this really brings us to the importance of having an efficient clinic throughput, something that we have recognized even more so during the pandemic. Some of the advantages of the faster 100 kilohertz engine are that it is significantly faster for both OCT and OCT-A than the predecessor Cirrus 5000. And what this really translates into is that it can offer a time saving of 1 to 2 minutes per patient without sacrificing your resolution or scan protocol. And if you translate that over a busy clinic across 50 to 75 patients, that adds up. The other advantage is that it allows you to track the scans using the repeat last visit function. And that is very helpful for the photographers to then obtain the same scans that you want, which is dependent on the disease pathology. The faster scan speed minimizes motion artifact, reduces fatigue. And these are features that are critical, especially as we transition from a more qualitative analysis of OCT and OCT-A data into more quantitative analysis. And as we try to integrate this quantitative analysis into our therapeutic decisions. So let's look at an AMD workflow. One of the key advantages I find of having rapidly accessible OCT-A is in identification of subclinical macular neovascularization. You can see in the OCT image on the left with the flow overlay that there is a long elevation of the retinal pigment epithelium above Bruch's membrane with a shallow height, which is typically less than 100 microns. And this shallow, irregular RPE elevation above the Bruch's membrane is a characteristic risk factor which will portend the presence often of a subclinical macular neovascular membrane. And you can see that on the right on this OCT image that reveals nicely a type 1 lesion. So it's a very rapid screening tool to identify such eyes, particularly those which do not have associated blood, retinal fluid, or thickening of the retina on OCT, or any evidence of leakage on fluorescein angiogram. This allows you to discuss with the patient the importance of increased surveillance in such eyes, because we know that the risk of exudation in such eyes is almost 14 times greater than those without such lesions. In exudative AMD, obtaining an OCT-A image really allows you to assess the morphology of the macular neovascularization in addition to changes in fluid that you see on structural OCT. You can use this to monitor parameters, for example, the diameter of the lesion, the area of the lesion, You can use it to get an assessment of vascular density, maturation of the vessels, as well as a reduction in the size of the lesion and change in morphology. And this is important because as our therapeutics advance in macular degeneration, we're going to increasingly recognize the importance of paying attention to the morphology on OCT-A. And this is where having a rapidly accessible OCT-A tool that allows you to obtain measurements that are compared with prior visits is helpful. You can see here over the course of 9 months that there is some remodeling of the lesion with a reduction in some of the areas, as well as a change in the vessel density. In cases with polypoidal choroidal vasculopathy, it is increasingly recognized now that OCT and OCT-A may be very helpful to identify branched vascular networks and polypoidal lesions, often even better than ICG angiograms. And as you can see here, there's a presence of a notched PED. I find OCT-A to be particularly helpful in my diabetic workflow because it really gives us very valuable prognostic information in a very rapid fashion. It's sometimes challenging to obtain fluorescein angiograms on diabetics frequently, and getting a wide field OCT-A that covers a large area of the posterior bowl is really helpful for prognostic information to identify the extent of ischemia in the foveal avascular zone, the irregularity of the FAZ, to identify areas of microvasculature dropout, as you can see here in the temporal macula, and also to identify areas of neovascularization that you can see in Ermar's or neovascularization elsewhere, which may not be seen easily on a fundus examination. It is also very helpful to monitor these pathologies over time as you're assessing response to anti-VEGF or pan-retinal photocoagulation treatment. It's quite a sensitive tool and can sometimes replace the need for obtaining frequent fluorescein angiograms in such patients. Similarly, in retinal vein occlusion, OCT-A, that is again, a very important source of prognostic information, because you can really appreciate here that the extent of ischemia that you can see on the OCT-A is significantly greater than what you would expect on the fundus photograph. And it's a much easier tool to obtain this information versus obtaining a fluorescein angiogram. As our understanding of OCT-A improves, and we probably will come up with definitions for ischemic vein occlusions that may be different from the 10 disc areas that were usually used for fluorescein angiograms. I see a lot of uveitis patients and find that OCT and OCT-A are extremely helpful in my uveitis workflow. So in an endemic country like India, where we often see tubercular serpiginous-like choroiditis, obtaining wide field OCT, particularly the average scan that gives you a high resolution, is very helpful to obtain high quality imaging of the outer retina that allows you to assess the extent of disruption of the ellipsoid zone and the external limiting membrane, assessment of the choroidal thickness and vascularity, and also obtaining OCT-A images, which at the level of the choriocapillaris showed oftentimes these dark areas which represent choriocapillaris flow voids and are thought to be on the spectrum of choriocapillaris ischemia. This is a very important way to monitor eyes that have the tubercular serpiginous-like choroiditis, to monitor for conditions of paradoxical worsening as treatment is initiated, and also monitor response to treatment, because you do expect to see a gradual reduction in the size of these choriocapillaris flow voids. And we've also recognized that there are thresholds for reversibility, and earlier treatment can often result in complete resolution of these flow voids. Similarly, in other uveitic conditions that involve the outer retina, like syphilitic placoid chorioretinitis, you can monitor the restoration of the outer retinal anatomy with treatment. And again, it's a very helpful tool, particularly combined with en-face OCT imaging. An area where I find the high resolution OCT to be particularly valuable is in imaging the choroid. So in cases, for example, with VKH, you can see that in the active stages, there is presence of subretinal fluid. There are irregularities in the outer retinal layers and thickening of the choroid and increased vascularity. And with treatment and initiation of immunosuppressive medications, there is resolution of the subretinal fluid, restoration of the outer anatomy, and a reduction in the choroidal thickness and vascularity. It is also important to recognize that OCT is a more sensitive tool to visualize the choroid in the outer layers as compared to ultrasound. So in cases with posterior scleritis, it's very helpful to use OCT to monitor response to treatment because you can really establish a baseline for defining disease quiescence, which is going to be below the limits of resolution of your ultrasound. And conversely, it is also very helpful for early detection of disease recurrence, even when patients are otherwise asymptomatic. So you can see here in a patient with posterior scleritis that on presentation there is subretinal fluid and massive thickening of the choroid with increased vascularity. And after initiation of immunosuppression, there is resolution of the subretinal fluid, restoration of the outer layers, as well as normalization of the choroidal thickness and vascularity. And as our software analysis improve, we may be able to use these metrics in routine clinical care as well. It's also important to pay attention to the choroid for early detection of disease recurrence. And you can see in these scans that were obtained 6 weeks apart, the patient was asymptomatic on the follow-up visit. However, there is a prominent thickening of the choroid and increase in vascularity, and that is indicative of a disease recurrence despite the patient being on immunosuppression. So this is an indication to escalate treatment. In cases of white dot syndrome, a combination of OCT and OCT-A along with en-face imaging is very helpful to try to distinguish the extent of involvement. So you can see here there is involvement of the outer retina as well as the choroid with increase in the choroidal thickness and vascularity. But if you look at the choriocapillaris slab, there is presence of these choriocapillaris flow voids, and this is often more indicative of AMPI as compared to MUDES. It is also easier to use OCT-A compared to ICG to determine the extent of involvement and also to monitor resolution because you can easily obtain follow-up tracked OCT-As on every single visit, and it may be less feasible to perform an ICG in a similar manner. It is also helpful to use this to identify thresholds for reversibility of these choriocapillaris flow voids. Another key area where OCT is helpful is in monitoring vitreous inflammation. So particularly as the acute inflammation reduces, you would use vitreous hyperreflective foci as a very sensitive marker to monitor for residual inflammation. So in this patient who had acute retinal necrosis, you can see that as the retinitis resolves and there is retinal thinning, but there is correspondingly also a significant reduction in vitreous inflammation with near resolution of these vitreous hyperreflective foci. These are particularly useful in pediatric patients because you can really get a sense of the activity level of inflammation. In patients with occlusive retinal vasculitis, again, OCT-A offers prognostic information. And it is also very helpful in these immune-mediated occlusive vasculopathies to monitor for reperfusion after initiation of aggressive immunosuppressive treatment, because the underlying process is different than a VEGF-driven retinal vein occlusion process. In cases with chronic central serous retinopathy, obtaining an OCT-A scan is quite helpful to identify the presence of small type 1 choroidal neovascular membranes, which may indicate a response to anti-VEGF therapy. I also find OCT to be quite helpful in surgical planning, particularly as we get high resolution scans with enhanced depth imaging. So you can see in this patient with a macular hole, there are different anatomical prognostic indicators, including the presence of an epiretinal membrane, the configuration of the macular hole, calculation of the inner opening diameter, the largest basal diameter, as well as the status of the posterior hyaloid, which is attached at the optic nerve. In this case, with the retinal detachment, you can see the presence of outer retinal corrugations that indicate a rhegmatogenous component to the retinal detachment, but also you can see that the posterior hyaloid is attached, and this impacts your surgical decision-making in terms of what treatment to offer this patient. And finally, I would like to talk about the applications of high-resolution OCT and OCT-A beyond just retina. The retina is a window to the brain, and there are applications in neurodegenerative diseases which we are just beginning to explore. So you can see here, there are 3x3, 6x6 millimeter OCT-A scans, retinal nerve fiber layer, and ganglion cell layer thickness maps. And you can see that they're subjects with Alzheimer's disease, Parkinson's disease, mild cognitive impairment, and an age-matched control. Another exciting application of OCT and high-resolution OCT-A is beyond the retina and looking at neurodegeneration. This is a hot area of emerging research because we increasingly recognize that the retina is a window to the brain. So neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, and even mild cognitive impairment, we are now detecting changes in the retinal microvasculature. In this example, there's a 3x3 OCT-A scan on the left, a 6x6 OCT-A scans in the middle column, and retinal nerve fiber layer and ganglion cell maps in the right column. And you can see that across the spectrum of neurodegeneration, in a patient with Alzheimer's disease and Parkinson's disease, there is a significant reduction in the vessel and perfusion density, which are metrics that are used to calculate the retinal microvasculature, as compared to an individual with mild cognitive impairment and one who's an age-matched control. So this is an area of research that we are pursuing, and we note that there are significant differences amongst individuals with cognitive impairment and Alzheimer's disease and Parkinson's disease compared to age and sex-matched controls. We also recognize that there are normal changes in aging in the retinal microvasculature, and these need to be taken into consideration as we move forward with integrating these measures into an index that may help us to improve the diagnostics of these neurodegenerative diseases. Earlier detection of such diseases will allow us to institute lifestyle modifications earlier in the disease process, and also in the future, evaluate therapeutics at earlier points in the disease continuum. And with that, I would like to thank you for your attention, and we'll open this up to questions.